Hello, this is David Bishai, and this is part 2 of our lecture on market power. And in this part, we're going to talk about cost shifting. The idea here is that monopolies can be harnessed for social good. The reason is that monopolies are typically going to require government regulation to stay in existence. They need some force that keeps away market entrants that are going to challenge their monopoly. And so one of the best ways to keep your monopoly is to get government to protect your monopoly. Governments are perhaps willing to do this to increase social welfare. They'll offer the monopolist protection in exchange for some socially desirable activity. An example that you're familiar with is that the government says to people in society, if you invent new technology, that's a social good. We will give you monopoly power because we want you to invent new technology. So we will harness your creative activity by offering you monopoly power for a short length of time in order to incentivize you to do something that you would not otherwise do. That's an example you're familiar with. The new example today is the government wants a firm to offer cross subsidies to poor people for health care. So we will offer monopoly power of some sort, not complete monopoly power, but partial monopoly power to hospitals. And in exchange, we want those hospitals to offer us a discount on Medicaid prices. We also want the hospitals to take care of uninsured people for free. So these are social goods, and we will make a deal, a quid pro quo, in order to achieve these social goods. And we wanted to go through the economics of this. Now, it's not obvious to everybody that the government is always doing the right thing when it does a quid pro quo. And in a way, this is a Faustian bargain that you're playing with fire. The monopolist is not really about doing social good every time. And in order to be a monopolist, the whole way it works is to restrain supply and not produce goods that society values. You have to do that to be a monopolist. So we're automatically saying we're going to have a deadweight loss in order to have the monopolists do their monopoly thing. The other parts are that the whole reason the monopolist wants to charge high prices is because people will pay them. Consumers lose. They will be paying prices that are above marginal cost for sure, and under monopoly. So somebody's going to pay a price that's higher than it would otherwise be. They will voluntarily pay those prices. It's not coercion. They see value in the product, but they're paying more than they would have under perfect competition. So we're definitely going to move money from consumer pockets to monopolists under this bargain, and we're going to have deadweight loss because we do not produce products that had marginal benefit above marginal cost. So the picture of this from our understanding of monopoly is this orange rectangle of windfall profits comes from consumers who are moving money from their pockets to the monopolist pocket. They do this voluntarily. They find that their marginal benefit is above the monopolist price. I prove it. This is the benefit to the consumer here on their demand curve, and this is the monopolist price. So the consumer says, sure, I will voluntarily pay the monopolist price, but counterfactually, they could have gotten this lower P star price if there had been perfect competition. So we are moving money from consumers to monopolists in order to get some social good. And as I said, that social good in healthcare is trying to achieve a way to take care of poor people. So this is one of the bad things in the Faustian bargain. And the other bad thing is the deadweight loss. This is this red triangle is consumer surplus that never ever gets created. These units between Q star and QMP never get produced. None of this ever gets made. If it had gotten produced and it had gotten sold at P star, it would have been valued all the way up at the demand curve. And that would have been a good thing, but it never happens. And so society loses this amount of value in the consumer's pockets. It also loses this other triangle, which is the producer surplus, never gets made as well. But the producer's just fine and dandy with that. The producer would happily trade away this tiny little triangle in order to achieve the windfall profits up here in this rectangular area. All right, so we've got a quid pro quo idea of offering the monopolist windfall profits in order for it to do something good. The bottom line is that the good thing we try to get our monopolists to do had better be worth it. It better be worth the deadweight loss and the consumers paying more than they would have. Now, one thing that politicians know extremely well is that if you do this deal with a monopolist, they're probably going to be very grateful, and they're going to show gratitude the way monopolists show gratitude. Ka-ching, ka-ching. They're going to want to make the politician happy. The second note is that the consumers who pay those higher prices under the monopoly, they might notice, but again, they're getting something that they value, and they tend not to go crazy with protests and political retribution against the politician running one of these quid pro quos. However, every now and then a politician can start an anti-monopoly movement and say, oh, those terrible monopolists are taking your money, I vote for me, and I will crush their monopoly and give you back lower prices. If that sounds familiar, that's what's happening often in the politics of pharmaceutical prices right now. Consumers are feeling the pinch of high pharmaceutical prices, and you're seeing politicians saying, vote for me, and I will reduce the monopoly power of the pharmaceutical industry because I'm the person for you. Going back on the quid pro quo with the pharmaceutical patents being a social good, saying let's take down that social good of invention of drugs in order to give you lower prices now. We will talk about that piece of monopoly later in the course. All right, so back to our quid pro quo. What good thing can healthcare monopolists do? The option today is that we want our healthcare monopolists to offer hospital beds for the poor. That's a public good. Americans and other countries' citizens, they like to take care of poor people. It's an altruistic public good. So a very most common way to provide the public good is the socialist approach to tax the citizens and use the money to buy beds for the poor at a price chosen by the government. And in America, we do the socialist approach, and we call it Medicaid. In other governments, they do it all the way. That in the UK, they offer the National Health Service, which does the provision of hospital beds completely using socialism. So in America, we have socialism working for us. However, we also supplement our socialist product of Medicaid, and I'm not using socialism in a pejorative sense, it just is what it is when you have government tax money providing a public good. It's called socialism, and it's great. I love it. I'm so glad there's Medicaid. Now, in the American approach, we offer a quid pro quo. We allow hospitals to give us these Medicaid beds at marginal cost or even lower than marginal cost, and we want our hospitals to offer charity care to the uninsured at $0 prices, and to get them to do that, we use a monopoly-driven quid pro quo. The idea is that the monopolist profit is a big pocket of money that the government sees as a charity fund. Now, the government can't take all of the charity fund, but it takes some of it and uses it to cross-subsidize, to cost shift, cross-subsidizing care for Medicaid patients, for Medicare patients, and for uninsured people. So in exchange for monopoly pricing, we offer the hospitals high prices for those with private insurance, and in exchange, the quid pro quo is we want Medicaid prices that are at marginal cost to start with. But hey, let's keep going and see if we can even get Medicaid prices that are below marginal cost. That sounds a little crazy to me. Usually you don't see a firm selling anything below marginal cost in the long run. But we're going to see that actually might be sustainable in healthcare. But you should be skeptical. How can any business stay in business selling units below marginal cost year in, year out for decades? All right, so let's take a picture of the quid pro quo. In this quid pro quo, we have our monopoly pricing system. The perfect competition equilibrium is here. The monopolist price is here, right up at P sub private. And we have the number of beds sold to the private market here at Q sub-private. There's this extra chunk of Q Medicaid, which goes on top of the private market to take us all the way out to the perfectly competitive equilibrium. What happens at the end of this quid pro quo is that the market has two prices. If you are a privately insured patient, you pay this high price called P sub-private. And if you are a Medicaid patient, you pay marginal cost, for now, at the price of Medicaid. So this is a way for us to have high prices for the private market and marginal cost prices for Medicaid. This is very sustainable. The monopolist is happy charging high prices for the private patients. But the government has said, in order for you to do this monopoly thing, we are going to cut a special deal and we will have marginal cost prices for people with Medicaid. The government can do this because it has enough political power in its state legislature to do this. Politically, the hospitals will try to say, listen, this isn't good. We would like to charge more for Medicaid patients. The legislatures will say, no, we don't think you hospitals have political power. We want to get marginal cost pricing for our Medicaid. So this is the extreme version of two-tier pricing because, as you will notice, this is the monopolist equilibrium. The monopolist quantity private is being restricted all the way as far as it can possibly go, and the monopolist price is right up here at the top of the demand curve. So this is monopoly pricing, restricting the bed supply to the private sector as much as it possibly can go. We would expect to see this if all hospitals were for-profit hospitals, because if you were a for-profit hospital, you are obligated to do this for your shareholders. In fact, if you don't do this, your shareholders will fire the CEO and say, we want a CEO that offers monopoly profits to us. All right, so this is if we have a fully for-profit hospital industry, but we don't. We have mostly a non-profit hospital system, and non-profit boards are not for-profit, they're soft-hearted, and we would expect them not to do full profit maximization. They might have a reason to not charge the monopoly price, and we're not sure they'll charge the perfectly competitive price if they have market power. But let's put them in the middle and say, if you are a nonprofit hospital, you won't be as greedy as possible and charge the monopoly price, P sub MP. You will charge the nonprofit price, P sub nonprofit, and you'll have a little bit of wiggle room. Now, because you have wiggle room, let me show you the wiggle room. This is potential revenue that the government sees out there every time it looks at nonprofit hospitals charging this nonprofit price. The government says, oh, look at your wiggle room. That orange rectangle is money that you have not collected from the private payers yet. And here we are, we're paying this marginal cost price for Medicaid. You're the government legislature of a state, you're paying this price here, the marginal cost price. You could do better. You want to get more of this orange rectangle to help you cut your tax obligation to the Medicaid patient. So what do you want to do? You want this price to go even lower below marginal cost. So here's the idea that's occurring in the minds of the state legislature. You want Medicaid to reduce its fee below marginal cost because you know there's wiggle room. You know the hospital can raise its price to private insurers, and presto, you want it to happen. Now, this is controversial. According to the theory of the monopoly, if the hospitals should have already been charging the monopoly price, why weren't they? Well, they're not for-profit companies is the answer. Some economists don't get that. They say if you're a nonprofit hospital, you should probably just charge the monopoly price, take that money, and then go do your nonprofit thing with it. Go hand dollar bills out to poor people, or pay whatever social good you want to do, you could do it with your monopoly revenue. But we see that hospitals actually go along with the quid pro quo. So it's clear to most economists that they don't start the day charging the monopoly price, they charge this intermediate price. So given that we see them able to do this, the full system of quid pro quo goes as shown in this graph. We start the hospital at its P nonprofit. Then along comes the government and says, you know that Medicaid population down here, Q prime Medicaid, you were charging them this marginal cost price. We now want you to charge us a discount, a price below marginal cost. Take a minute to notice that this price for Medicaid is well below marginal cost. It's well below the perfectly competitive price, which would have been here. Government says, hospitals, charge us this discounted price below marginal cost. And the hospitals have to go along, and they can go along as long as there's wiggle room to increase the price to the private sector, going from this nonprofit price up to the price of the monopolist, P prime sub MP. So it has to do this in order to cover the losses on these below marginal cost units to Medicaid. Up goes the price to the private payer, down goes the price to Medicaid, and we as economists ask the question, is this sustainable? Now notice that if the government does this right, they get the price in the private sector to reach a maximum. It can't go up anymore because this is as high as the demand curve is. You cannot charge a price higher than the demand curve at your monopoly quantity. Will it work? So the next slide tries to answer the question, will it work? When the monopolist goes from their nonprofit price here in the middle, right on the upper right corner of the pink rectangle, it goes up to the monopoly price, it has to restrict quantity demanded, and it loses these units in pink box B. It's no longer selling these at the nonprofit price. So it loses these box B units, they're lost, but it gains revenue in box A. Now, the QMP is the new quantity supplied, and the new price is the P prime MP, so it gains revenue of box A. The total gains of this system is box A plus and box B minus. Is box A bigger than box B? I sure hope so. I don't know if I've drawn it to be bigger, but it can be bigger. And as long as box A minus box B is a positive number, the hospital has room enough to take the loss shown in the red triangle. These are units that are being sold at P prime Medicaid, so it costs, the revenue for these units is P prime Medicaid, but it costs the hospital all this much money to make these units. And so this is loss that the hospital has to swallow. And so it's feasible and sustainable as long as box A minus box B is bigger than this red triangle of losses of units, marginal cost higher than the revenue collected from the Medicaid payment. And this is true. This actually happens, and I will prove that this actually happens. In this slide, I've graphed for you Medicaid and private reimbursements over time. So the upper green line is the ratio of payments to hospital costs. And here, this green dot here at the far left shows that private patients in 1980 were paying about 1.1 times cost. They're paying more than cost. Medicaid patients, this solid line here, shows that Medicaid patients were paying 0.95 times cost. So it was costing the hospital $1, Medicaid was paying 95 cents. Over time, by 1987, Medicaid started to pay 0.8 times cost. It would cost the hospital $1 for a Medicaid patient, and Medicaid would reimburse them 80 cents. Meanwhile, the hospitals said, we need the quid pro quo to happen for us. We will now raise our prices to the private patients, and they started to do that all the way up till 1993. They were charging their private patients 1.3 times. So it would cost a hospital $1 to take care of a private patient, but they would charge the private patient $1.30 in order to cost shift and cover their losses on the Medicaid patients. Well, Medicare is here in the middle. They're being just as stingy as Medicaid. In the late 80s, early 90s, Medicare also started to get cheap and pay hospitals 85 cents on the dollar. So the more the federal payment system squeezed the hospitals, the more they would squeeze back to their private market. In the 1990s, late 90s, early 2000s, Medicare and Medicaid got generous again. They started paying closer and closer to marginal cost. And private payers got powerful. And they started to say, we're not having this anymore. We don't want to pay you $1.30. We want to pay you 1.25, 1.15. We are going to lower our cross subsidy to you. And the hospitals had to take it. Now, this is a mixture, right? So partly the private payers are pushing back on the hospitals. The hospitals are going back to Medicaid and Medicare saying, we will go bankrupt. We will leave your state if you don't pay us closer to marginal cost. But both things are happening. There is a push from the private sector. There's some give room from the government payment systems. Let's move on to the 2000s. In the 2000s, the private payers got stingy again. They started lowering their reimbursement, paying 85, 90 cents on the dollar for the federally insured and Medicaid insured customers. And up go the payments to the private sector. Private sector is now looking like about $1.45 for every dollar's worth of care. So there's cost shifting. The system had the ability to charge higher than marginal cost charges and cost to the private payers. And this is what we see happening. Now, the data for this curve are coming from the American Hospital Association. And we should be skeptical that this black line in the middle, this 1.0, is exactly where I say it is, that this is the actual cost. If I were the American Hospital Association, I would overestimate my costs. And so perhaps this black line might be lower down here. I'm not sure. But I think it's pretty striking that every time the blue curves at the bottom go down, the green curves at the top go up. That's real data. And every time the green curves go down, the blue curves go up. So this is showing that there's cost shifting, that the hospitals are getting money from the private sector to make up a deficit from the public insurance. Now, if we do a little bit of statistical analysis over this entire range of data for these 36 years shown in the graph, every time we move the Medicare cost ratio down by 1 point, we move the private payment up by 0.92. So every dollar they lose from Medicare, they make up for with 92 cents coming back from Medicare. And this is a statistical analysis I did adjusting for Medicaid payments and a cubic function in time. I put in terms from time squared, and time cubed to give you this ability for hospitals to claw back money from the private sector when it loses money from the public sector. So the other side of this story, besides both the government legislatures just shoving it to the hospitals and saying, we're the legislature, you have to pay what we pay you, is a story of private sector market power. What is happening over this time frame is that as these green payment to cost ratios were rising in the late 80s, this was a time of high provider power. This is the time of a medical arms race where hospitals did not have to compete on price to keep their patients in the hospital. They competed on luxuries like fancy wall-to-wall carpeting and sculpture gardens. They competed, obviously, on fancy machinery and capital, but they did not offer price concessions to the payers during this era in the late 80s of a medical arms race where hospitals would fill their hospitals with devices rather than offer price concessions. Starting in the early 90s, at this transition point, the payers began to form large conglomerates and have concentration, and they used that power to bargain back down their fees, and we see this era of declining payment to cost ratios. After the 90s and the early 2000s, the balance shifted again. The hospitals started to consolidate and form large hospital chains. Now we have chains here in Maryland. There's the MedStar chain. There's a Johns Hopkins chain. There are many, many chains of hospitals all around the country that existed in order to gain market power, to push back and negotiate up the payment to cost ratios to push back against the consolidated payers. So in the next section, we're going to talk much more explicitly about this bargaining game on the private side as conglomerates of insurers and large insurers gather power to push down fees. Hospitals gather power to push back up fees. So stay tuned for part 3 as we go over that development in the American healthcare industry.